Welcome all. The topic of today's discussion is about neonatal diabetes mellitus. The important thing about this is also known as a congenital diabetes or diabetes of infancy. It is basically a monogenic defect which is most common under 6 months of age. If you go with your prevalence, it is around 1 in 90,000 of live births, and it is basically categorized into two types: transient, permanent, and syndromic. So, what neonatal hyperglycemia versus diabetes mellitus? If you see, the neonatal hyperglycemia is more common to develop in first 3 to 5 days of a life, and it usually resolves within 2 to 3 days of onset, but it can persist up to 10 days. Remember, so it is a hyperglycemia which can persist up to 10 days, and it is not a diabetes mellitus. So what will be the prevalence of a hyperglycemia in a preterm infant? It is around 25 to 75%. So next thing is what are the risk factors for hyperglycemia in newborn infants? You know, any preterm birth, any IUGR baby, increased stress hormones, early and high rates of intravenous lipid infusion, higher than needed rates of IV glucose infusion, and absence of enteral feeding, which leads to a diminished incretin secretion and action, limiting their potential to promote insulin action. So you know the risk factors we again enumerate, like preterm birth, IUGR baby, more than usual IV fluid, or absence of a enteral feeding. Now, what are the genetic basis? This is an important question because in MCQs you will be asked regarding this only. They have already asked many times about which gene is most commonly involved in neonatal hyperglycemia. It is a KCNJ11 gene and ABCC8. Both affect the pancreatic beta cell potassium ATPase channel. And if you find the percentage, it is around 40% of these patients. So what will be the mechanism? It is basically alteration in the beta cell function, which affects the synthesis or the secretion of insulin by three genes like KCNJ11, ABCC8, and INS. Or the second mechanism is a pancreatic hypoplasia or aplasia. The genes which are most common involved are PAXis, Neurod, and PDX1. Third mechanism, it can be due to damage to pancreatic beta cells. The gene involved is INS, FOXP3, and WFS1. So please remember all these genes. You will get out of these, you can have all four choices, and the important and the most common gene involved in such disease is KCNJ11. So next, what we need to know, this pathway. Remember, you can have a glucose with the help of a GLUT2. The glucokinase will act, leading to dihydroxy. This all is about glycolysis, and this is about TCA cycle, leading to generation of a ATP and ADP, which will move a potassium ATPase channel. So there can be defect in all these things, where at the end insulin granules has to take part. So what is a transient diabetes mellitus? Usually it resolves around 12 weeks. However, approximately 50% of the cases will ultimately relapse after a certain period of a time. And in transient DM, the insulin dose requirement is very less if you compare it with permanent neonatal diabetes mellitus. And in transient, another peculiar point is that it is mostly associated with IUGR and the association of a macroglacia and umbilical hernia. You know, you come across such babies who are having a hernia, you say it is normal, you need not to come. Your Nelson says you can wait up to 2 years. Now they are saying that you can wait for 5 years. So any baby with multiple inguinal hernias, macroglacia, look for transient diabetes mellitus as an association, and the expression of a genes on 6q24 is the most common cause of a transient neonatal. So anybody who has transient neonatal diabetes mellitus, most gene involved, it is 6q24. And the second most common cause of a transient neonatal diabetes mellitus is mutation in two genes which encode a voltage dependent potassium channel. So transient neonatal diabetes may caused by either KCNG11 or ABCC8 cause a clinical picture that can be indistinguishable from your most common cause, that is 6q24. But the differentiating feature is that the birth weight is typically lower when you get a gene related to 6q, and the onset of a diabetes is very early, and as does the remission in your 6q24 gene. So what about permanent diabetes mellitus? This is important part. I told you the most common cause is KCNJ11 or ABCC8 mutation. 50% of a case belongs to this only. The potassium ATP channels are also expressed in the brain. So patients with these type of mutation have so many kind of a neurocognitive dysfunctions also. So remember, it is not going to get, you will get a permanent diabetes mellitus. You can get a different neurocognitive dysfunctions also. And if somebody has more, second most common gene, it is INS, insulin sensitive gene. So KCN, what is the mechanism? It causes decreased sensitivity of the KIR 6.2 subunit to ATP with failure of the channel closure. And consequently, what happens? There will be insufficient or absent insulin release from the beta cell. And if you will not have insulin, the sugar has to rise. And if your neurological features are there, I told you that this KCNJ11 is not present only for your diabetes, it will also act when it is deficient in your cranial system, where syndrome is known as a dent syndrome. So the classical facial dysmorphic features are the prominent metopic suture, baby will have a bilateral ptosis and downturned mouth. So, what are the different syndromic forms that can be associated with your neonatal diabetes mellitus? So, you need to remember five of them. Walker-Trellison syndrome, the mutation, it is autosomal recessive, and the gene involved is EIF2A. Second is IPEX syndrome, which is FOXP3, Fanconi-Bickel syndrome, which is SLC2A2, then followed by Rogers and Wolfram syndrome. So you need to remember all these genes to crack exam. Now we are done with our neonatal diabetes mellitus divided into transient and permanent. Transient we did, and we see that the which type of a chromosome or a gene is most commonly involved. In permanent, what are the genes which were. So now we will move to clinical presentation. You can have a different form from asymptomatic to severe diabetic ketoacidosis, and the baby is usually SGR IUGR baby. Postnatal growth is hampered, and you can find other features like lethargic irritability and sunken fontanellas. These are non-specific symptoms. So what diagnostic workup we will do? We will take laboratory test, then we will go for a genetic test. What laboratory? Like you need to have serum glucose level, C peptide, insulin, urine ketones, pancreatic USG, and if somehow HbA1c, but it is not in a neonatal period. So what are the genes? We discussed already that 2-3 genes are very important to differentiate between genetic test. So KCNJ11, ABCCT gene you have to identify, and the peculiarity about these genes are that if you suspect this and you ask for these tests to come, till then you can start with sulfonylurea therapy, because these are very sensitive and very responsive to such therapy. So what are the recommendations? If you have a less than 6 month baby, you need to have a molecular genetic testing to label it as a monogenic neonatal diabetes mellitus or type 1 diabetes. So 6 to 12 months, what you need testing for NDM is recommended in those without islet antibody, as the majority of patients in this group have type 1 diabetes. So what will be the treatment? We discussed the clinical features, we discussed the lab parameters, now the treatment. Infusion of insulin or your subcutaneous insulin alone, or you have a new advice, continuous subcutaneous insulin infusion, or oral sulfonylureas, or transition from insulin to oral sulfonylurea. These four options are available with you. So what will be the insulin dose? Initially it is 0.05 units per kg per hour. Then it will be titrated to 0.01 units per kg per hour. So what about subcutaneous insulin? You have to start Lispiro or Aspart, which are very short acting. The dose is 0.1 to 0.15 units per kg per dose or dose guided by the response to IV insulin. So what could be the blood glucose level? Target is 200 to 250 milligram per deciliter. If it is the uh, glucose which is above this value, then only you can go for subcutaneous insulin, or you can give a glargine at a dose of a zero point 0.2 to zero point 0.4 units per kg per day in 1 or 2 injections per day. So now there are continuous subcutaneous insulin infusion available. This allows a very physiological way of getting a continuous basal dose. So what things you need to consider to know: the infusion pump settings, type of infusion set and tubings, method of insertion, what are the law features, what is waterproof casing. Something about sulfonylureas. The most common cause of a neonatal diabetes are usually responsive to sulfonylureas. So 90 to 95% of a patient with neonatal diabetes caused by KCNJ11 may be successfully transitioned, and therapy is of immense help. So you know that a trial of glyburide may be considered in the newly diagnosed neonatal diabetes because of a relatively high chance of having a mutation responsive to treatment. Trial of sulfonylurea therapy can be considered even before a genetic diagnosis is made, although genetic testing must be done in all cases. So what will be your approach from insulin to oral sulfonylurea? The basal rate should be reduced by 50% prior to your glyburide administration. Glyburide tablets should be crushed and should be prepared in aqueous suspension. An initial dose to start with, it is about 0.1 milligram per kg per dose that has to be administered BD before meals. And you can increase the dose by 0.1 milligram per kg per dose. So this is the, and what will be the response? The glucose and C-peptide levels may be drawn before a meal and again 3 hours after meal is eaten, and in between glyburide is given. So with appropriate response to glyburide should have an appreciable increase in C-peptide level following your glyburide dosing and a meal. So what are the learning lessons? Long-acting glargine pen to avoid it if dose is less. Sulfonylureas to be started as early as possible. Continuous infusions better option, and continuous blood glucose monitoring better than conventional checking. Thank you so much. So this was all about neonatal diabetes mellitus. You have noticed all the things and all the MCQs we done, which can be a potential MCQs for the next upcoming exam. Thank you very much.